Welcome to Ready to Talk, Ready to Listen, a podcast about all things mental health. CHE Behavioral Health Services interviews guests as they discuss relevant mental health topics and speak with our industry's top leading trailblazers. Let's get started discussing behavioral health and ways to support our mental well-being.
Hi, Dr. Larkin Hoyt here. I'm the host of Ready to Talk, Ready to Listen podcast, where we feature top experts and leaders and those interested in behavioral health care and mental well-being. This episode is brought to you by CHE Behavioral Health Services. CHE offers comprehensive mental health care, including in-person and telehealth psychology and psychiatry services. Listen, Dr. Valentine and Erin Carroll are our guests today. And I wanted to just plug that Americans are experiencing greater stress, anxiety, and depression than ever before. And before we go into talking through substance use disorders and our guests, I'd like to say what CHE's mission is real quick. And our mission at CHE, Caring Health for Everyone, is to provide access to care and support people to improve their quality of life and their emotional well-being. We have actually over 850 professionals committed to providing gold standard and evidence-based behavioral health care. We've got actually Dr. Dan Valentine as one of our clinicians at CHE. But more importantly, to learn more about CHE or to book an appointment, please call us at 1-888-831-2618 or visit cheservices.com. So today I want to introduce to the audience our guests. I'm very, very excited to introduce Dr. Dan Valentine and Erin Carroll. And instead of me reading your bios, I thought you two could, share a little bit about your experience as behavioral health professionals. And it's really your opportunity to do some bragging. So, Dr. Valentine, please brag away.
Well, thanks, Larkin, and welcome to the audience here. I'm Dan Valentine, and where do I begin? I actually would like to give a perspective of my history in addiction treatment field, if you will. I started my training in 1974. So I've kind of come across the whole spectrum of addiction treatment and its kind of involvement and evolution as it's gone from really primarily treated by paraprofessionals who are only in recovery. And I happened not to be in recovery during those times. So I was sort of an odd duck. But as I went through my career, I really caught the bug, if you will, in terms of treating addiction individuals and learned from a lot of mentors over the years. I went to eventually run different treatment facilities in San Diego area, in Orange County, and have spent some time working with the NFL and treating the athletes in that particular arena. And I think I'll leave it at that in the sense that I'd like to give perspective on this podcast about just the evolution of addiction treatment in America since, the mid 70s, really.
And I'd like to plug, you also have been in executive leadership the majority of your life outside of the clinical aspects. You've also served plenty of roles in executive leadership, helping to shape policies and programs through the years as it relates to addiction and behavioral health.
Yes. Thanks, Larry.
You bet. Erin, you're going to follow Dr. Valentine. I think you can do better.
Oh, goodness. Really hard to follow Dr. Valentine. He definitely is an addictions man and has just been led groundbreaking, treatment and been a huge hero in my eyes. Having worked with Sharp and achieving the Baldrige Awards there, that's something that, as a executive leader, I was always very impressed with. So hard to follow. My background is quite different. I'm a nurse. I've been a nurse for 32 years. Ooh, I guess I shouldn't have said that number. And basically fell into addiction like many others do, that we had compassion and have experienced addiction in every form of medical delivery of care. I started in the emergency room. What do we get in the emergency room? Overdoses, traffic collisions because of drunk driving, harm, domestic violence is usually coupled with that. So you see a lot of addiction in emergency medicine. From there, I went into the correctional institutions and see a lot of addiction in correctional institutions, especially when they're coming into the prison or jail and they're actively withdrawing, and we have to treat that. So I had an indoctrination into addiction just by being a nurse and working in many different areas of the hospital. For the last 10 years, I've been in psychiatry primarily, and addiction is dual diagnosis and managed outpatient programs, inpatient detox, and also intensive outpatient and PHP, partial hospitalization programs. I guess we could talk about it later, but at this time I'm working in psychiatry, human behavior at University of California, Irvine. And we treat a lot of psychiatric disorders and dual diagnosis there in the outpatient programs.
Well, I'd like to plug in, Larkin, if I could, working
please.
with Erin. It's been an honor to work with her several years ago at a treatment facility together. And I want to say the quality of care is really important as we talk about in my opinion, of ensuring quality standards, high standards for treatment for addicts and alcoholics. So I want to kind of punt that back to her. That she's my hero too.
I can't say, well, I'll say we can all get warm and fuzzy here because collectively, both of you guys are my heroes. I know the three of us, just to inform the audience, we go back several years together. We've worked at NABH together, National Association of Behavioral Healthcare. We've sat on committees together as it relates to substance use disorder. We've been able to share, trends and education and leadership together, even though we've worked in different institutions and different organizations. I really think it's just, kind of been a wonderful collaboration through the years. Not only are you guys great colleagues, but have also developed into dear friends of mine. And I have to tell the audience that we're just so lucky to have these two because they really are going to teach us a little bit about addiction. And for, Erin and Dan know me very well that I love to stigma bust anytime I have an opportunity where we can really talk about sharing awareness and pushing back on the misnomers and myths of mental illness and substance use disorders. The better off we are as communities, the better we can together have a sense of belongingness and help combat behavioral issues or any type of social issues that not only children in development go through, but adults do, and we can keep our communities together. We can do that through understanding mental health and understanding addiction, and again, like I said, not letting stigma get in the way for us to get access to healthcare. So I want to ask you guys a couple of questions in that vein of truth. How if our mission today is to teach the audience about addiction and how to stigma bust. I've got questions for you guys. Are you guys ready to answer them?
Let's go for it.
All right. So I'm gonna pitch this one to Dr. Valentine first. And I know this is a big question, and it's probably going to be hard to answer. You could probably just spend a whole podcast on this question alone. So I want to be sensitive to your time, and also warn you. So with this question, I think that our audience really should know is, can you tell us about the state of addiction in our country now? In other words, how is it bad? How bad is it? And if so, why are we in this place now?
Yeah, great question. Start off here. It's clear that addiction is a public health crisis. It affects every aspect of society. I was doing some statistical polling the other day. Over 20 million people have and are struggling with addiction. That's about 6% of the United States population. But at any given time, 10% of individuals will have problems with substance abuse during the course of their lifetime. So it's pervasive, 1 in 10 across the country. Virtually everyone knows someone or someone who has had an impact, probably negatively, on a family, on a loved one, et cetera, and on society. I mean, here's a couple other statistics. 107,000 overdose deaths a year. And that's more than breast cancer, guns, and car crashes combined. It's an astounding number. We isolate a bit, and the stigma, we'll talk about that later, but we isolate these statistics and numb ourselves, perhaps with substances sometimes, numb ourselves to the impact that this addiction has. And there's another 175,000 people that die each year to alcohol and drug-related physical defects and deformities and dysfunction. So there's a lot of things, and Erin could talk about this as it relates to hospital visits. Probably a big percentage are alcohol and drug-related that come in the emergency room. But here's another final number I want to point out and give perspective. Almost $750 billion is the impact on cost to society. And if you look at the gross domestic product, which is the total sale of goods and services annually in the United States, that's 21 trillion. So almost $1 trillion. We're throwing these billions and trillions numbers around like they're nothing, right?
Right.
Almost $1 trillion goes to the effect of drug and alcohol and the negative impact on society. And we just have this burden that's gone on, and it's like a tsunami that's come at us.
If I were to read between the lines, Dr. Valentine, of that message, I think probably what you're probably saying to us in the audience is that it would behoove us in our communities to invest in prevention and intervention programs. Not even if you may have your own issues as it relates to substance use disorder, your own bias towards it. Even if you slice that up and say, well, I'm biased and I don't want to treat substance use disorders. I don't think there's a lot of people out there like that. But let's just say there are some of our listeners that are like that. You're saying bottom line is that it really impacts our communities widespread. It's beyond just those that struggle with addiction or the family members that have it, that if we don't do anything, that if we don't invest in prevention or intervention programs within our communities, we're going to continue to be straddled with this debt.
Absolutely. And you catch it upstream. If we can chop down the little sapling before it turns into this wild oak, that takes us much more effort on the treatment end when addiction is out of control and affecting people in really harmful ways. If you can catch it early on and educate and steer people, that's certainly the right way to go.
Well, thank you, Dr. Valentine. Erin, I've got a question that I think kind of piggybacks nicely from the question I asked Dr. Valentine. So many people have different understandings of what addiction is, right? Some people think like, hey, if I have a glass of wine every night with my chicken or my fish, am I addicted to alcohol? Or if I use prescription medicine from my medical doctor because of a medical condition I've been diagnosed with every night, am I addicted? And I find that there are so many variations of the definition within our communities. So could you help us set the record straight and explain to us what the definition of addiction is in accordance with behavioral health professionals?
Sure. I'm a nurse, so I go clinical immediately.
Well, we appreciate that.
The DSM-5, which we use, there's a criteria that we look at when a psychiatrist or a addictionologist is going to make that kind of a diagnosis. They look at criteria that fall under 4 basic categories: impaired control, physical dependence, social problems, and risky use. So using more of a substance than is intended or using it for longer than it's meant to be is kind of the basic language. And then we break it down into those 4 categories for DSM-5. So that's for a diagnosis from a doctor. We also have tools in diagnosing what is an addict, what is addiction, by looking at, they call it the 4 C's. So it's helpful to remember just in a layman's terms. We use this in addiction treatment centers across the country. The 4 C's are compulsion, cravings, consequences, and control. So when we're talking about compulsion, we're meaning that the individual has an absolute or overpowering urge to fuel that addiction. We know that addiction is a chronic dysfunction, right? And it involves the reward, motivation, and memory systems of the brain. So when we separate it into these 4 categories and we break it down, then we can kind of classify whether a person is an active addict at this time, right? So we can apply that to any kind of addiction. If we're talking about drugs, alcohol, gambling, video games, sex, caffeine, whatever. You can apply these 4Cs to it. So compulsion, the behavior may start impulsively, but as the addiction grows, it becomes a compulsive habit. When you don't partake in the habit, you can have agonizing anxiety and it can affect other behaviors. So that's kind of compulsion. With craving, it's the urge to fuel the addiction. It becomes demanding, as in like a hunger pain or mimicking a physical need. It feels like vital for your survival. It manifests in like restlessness. You'll have insomnia, lack of appetite, and that's kind of the craving of the 4Cs. The consequences, that's when you have negative consequences that become apparent, like your behavior and use of this substance can affect your relationships, your work. You can have legal problems, you can have money problems. That's the consequences. And then control is something that we talk about a lot, is how the individual feels when their addiction is lost. And often in the early stages of addiction, an individual will try to cut down or eliminate the behavior, but this is impossible when the lack of control stage of addiction is reached. So those are the 4. It's a simple approach, but it's something that we use to help, kind of understand what level of addiction we have.
No, that helps. I think that's helpful for the audience too, to conceptualize it, and so it's not just really what I hear from you is it's not just really about, oh, 1 glass of wine means I'm addicted. It's really looking at how our life, our ability to function within our life and what kind of impairment comes up for us as the addiction, gets more breath, right? So in other words, if I'm like trying to understand if a friend's addicted, I mean, obviously I should go to a mental health professional first, but then maybe even asking that mental health professional to look at those 4Cs, that's probably something that's very common in the language I hear. So really looking at compulsion, craving, consequences, and control or lack of control.
Right.
That is really helpful to understand how mental health professionals conceptualize addiction, and I bet, and we could probably talk about this a little later, how intervention and treatment is kind of wrapped up in addressing those particular Cs.
Go
for it.
Just mention really quickly to even make it a little bit easier for the audience. The 2 Cs that are most prevalent for an individual to observe another in is the loss of control and the negative consequence. Because those you can see. And the key is more than someone intended to drink is loss of control. They drink more than when they said they were going to drink 1 and they drink 21. The other one are negative consequences related to loss of work, like Erin was saying. So those 2 are the ones that are going to be seen by an individual on the outside, I think, a bit more.
No, I appreciate you illuminating that for the audience too, because that is something that I think a lot of people can, hang their hat on when they're wondering about their loved ones or themselves, really.
Sure.
Dr. Valentine, now that we have some understanding of what addiction is, thank you, Erin, for illuminating that definition for us. Why is it so stigmatized? I know we talked a little bit about this at the beginning of the podcast, but why is addiction so stigmatized? And before you answer that, I read something really interesting from the WHO, the World Health Organization, the other day, that addiction is the most stigmatized disease in the world. So out of all mental and physical diseases, the World Health Organization says, no, addiction's the most stigmatized. Why is that? And can you help us shed some light on this?
Yeah, that's a huge question there. And I'll start off by saying it depends how a person defines addiction. And what I mean by that is if they have a moral belief that this is just a weakness of character and that they should just stop drinking, you're going to have more of a negative view because people don't understand the nature of addiction as an illness. And that's the other part that both Erin and I are comfortable with and have treated from a medical perspective or disease perspective. With that, you have a tendency to have a little bit more compassion, and the stigma may still be there because we've all been exposed to negative experiences of an alcoholic or drug addict. But I'll just say, let me just talk about how this is all come forward. Here's an interesting tidbit. The DSM, as Erin referenced, the Diagnostic and Statistical Manual on mental health and other illnesses, psychiatric illnesses. In the first edition in 1952, they defined alcoholism and drug addiction as part of their sociopathic personality disorder.
Wow.
Mhm.
Wow.
They actually pathologized, if you will, and created almost this sort of monster-like effect as person running around out in society, maiming and robbing and pillaging, the world. And so that was the professionals' definition. Can you imagine what we then would think? There were films in the middle 30s and 40s. I'm just starting from the beginning here. One called Reefer Madness, which showed a portrayal of individuals just going crazy on.
I think I watched that in high school just to date myself.
It's a classic, and it's been around for a long time, obviously. But and so that starts to show and put fear in individuals. Like, I don't want to be associated with an addict or an alcoholic. They're crazy.
Mm-hmm.
They're crazy, and a lot of mental health professionals wouldn't touch treating addiction up until very recently, when new modalities, I say new, meaning last 15, 20 plus years, cognitive behavioral therapies, motivational interviewing techniques really started to allow the mental health professionals go mainstream professionals treat addiction and substance abuse.
Mm-hmm.
So that's part of it. But a couple other things about stigma. So we've got that image, but people have been negatively affected. So they're going to naturally generalize and have a negative connotation. A lot of people were raised with alcoholic fathers and mothers, and the trauma associated with that. So it's very real and personal. And as a result, and we'll talk about this later, people then don't seek help.
Mm-hmm.
Stigma. It's a huge barrier, both internally with the person, but also externally from what society is going to think.
It's so interesting that you take us back to kind of some of its origins and its impacts of the videos and the things like that were written in DSM in the 50s and et cetera. And it does really give you this crystallized picture of how stigma was really introduced and paired with addiction. I often read myself about and challenge this all the time, but specifically about the moral failure of addiction, right? That people who struggle with this disease are, at this failing point moralistically. And it just always gets me really pumped up in a way that gets me a bit angry sometimes, because I get so frustrated that that's paired, because there isn't a moral failing with breast addiction or, I mean, not breast addiction, breast cancer. Yeah, sorry. Yeah. That's a different discussion. No, I digress. There's, with all these other diseases out there, there isn't this connection to moral failing. But I think, Dr. Valentine, when you shed light on, like you said, the earlier psychopathology that was connected to addiction erroneously too, really didn't give us a great starting place to help these people get treatment in a way that is, kind of in service and in help, and not viewed as terrible people, but people with disease and addiction, and that they need the help that they need to get. Right. And so I can.
I just wanted to add.
Yeah, go for it, Erin.
I think there's a lot of work that we need to do internally too. Sorry, my phone's going off. Internally in the medical, in our medical community. I think that we still have stigma. I see that in different levels of acute medical center, in the emergency department. People get very frustrated that they feel that, I've heard nurses speak about this, that their first interaction or coming across a patient that uses cocaine or heroin has their own personal mores, and they approach the patients with trepidation or fear because they've been told all of these terrible things are happening. This is why they're weak people. They could be crazy. The same kind of stigma that surrounds our psychiatry and that we're trying to break by educating our providers in the hospital. But I think that also parlays into the lack of treatment and compassion. And often we have to like remind each other, find our humanity and remind each other that this is a chronic disease. And this is something that affects their brain and is hugely dependent on genetics. And it is something that can last a long time. And having relapsed and treatment is common with just like any other disease.
Mm-hmm.
I was going to ask you that question, but you kind of laid it out for us already, and I appreciate that, Erin. Some of the research that's been out there recently has said that it takes 8 years to get 1 year of remission when treating a substance use disorder, and it takes 4 to 5 years after remission for risk of relapse to go down by 15%. And sometimes when I look at that, I go, wow, those stats seem dire. But then I try to change my perception of things and say, well, is that similar to some other diseases? Sometimes like I've read or have heard oncologists talk about the risk of cancer only goes down, like the 5-10 year mark. Why does the risk remain so high, or is it high?
It is high because, it's not, this is a brain disorder. Whether we think that they have, this is because they're morally inept or have, no self-control. That's not true. We know that this is a brain disorder. We know that the repeated use of alcohol and drugs can cause changes in the function of the brain circuits that are involved with pleasure, the reward system, learning, stress, decision-making, self-control, all of that. So it makes somebody that has a predisposition and a genetic factor and then have the use of those substances even make the disease more severe. Mm-hmm. And so then that moves in, it is a chronic disease. It can have episodes of acute episodes, acute withdrawal, of course, is an acute episode, or if they're, intoxicated and under the influence and having a crisis, like, with alcoholism or whatnot, you can have meth psychosis. Well, those are all acute episodes, but then the chronic treatment, it's a chronic illness. It's similar to hypertension and diabetes. Because we're going to, just like diabetes and hypertension, you're not going to take one pill and say, oh, okay, I have high blood pressure. I'm going to take one pill. Okay, now my blood pressure is treated.
Sure.
No, your blood pressure is not treated. Your blood pressure is influenced by weight or genetic factors.
Your blood pressure is managed, but
right,
it's not
managed. Exactly.
Right.
Just like your diabetes would be managed. So that's where we have to understand that the course of one remissions and relapse is part of the disease. And we as medical professionals, I think we need to really manage our countertransference and keep that in check so that we're not disillusioned by, a patient that comes in and is having another, coming back into treatment. Right.
Sure. I think, you got me you gave me a picture in my head. I have a dear friend that has MS, and he often describes it as remitting and relapsing. Mm-hmm. And it's a chronic disease, right? It's progressive, it's chronic disease. And, I think every time that he is having a relapse and he might need medical attention, whether that is in an inpatient setting or, a higher level of care, he's always handled with such care when he goes and steps up into inpatient. Mm-hmm. There is no moral failing for him. He's right. just people are there with open arms and saying, hey, that you're struggling right now. And I would love for us to get to a place where we view addiction very similar to that, right. In that it's a brain disease, it's relapsing, remitting. And if people need a higher level of care because they're going through a relapse, then let's do it with open arms. And so I appreciate you shedding some light on that for us, because it's incredibly complicated, but it goes back to what Dr. Valentine said, is that, that whole misnomer of moral failings really does follow the disease in a way that really prevents people getting the access and the care that they deserve. Right. But it's great to hear from two professionals that see addiction very differently and see it as a chronic disease state that doesn't have those moral failings connected to it. Dr. Valentine, I got a question for you. The latest publications show that 46% of Americans have at least one family member or close friend who has struggled with a drug or alcohol addiction, but only 10% of people seek treatment. Can you help us understand the barriers that prevent them from getting the help that they deserve?
Yeah, that we touched on that a little bit, earlier around the stigma piece, because stigma leads to guilt and shame. Mm-hmm. in an individual. If you can put yourself in an individual's shoes when they're looked down upon for having an illness, as we just highlighted, as Erin did so well. There's a fear of losing your job, losing your family, losing lots of things that the negative consequences, right, that we talked about. The other element around treatment is denial. The last person that recognizes the problem usually is the alcoholic addict themselves. There's a great supporting cast that helps keep them minimizing their use and the negative consequences till it gets too blatantly obvious. But let me take the other strain too, the other pathway of treatment and lack of access, inadequate treatment, and in the unavailability of treatment. Only 1 in 10 receive treatment, partly due to some of those stigma barriers, but also the treatment addiction field has been somewhat limited. It started in this country with an abstinence model, which meant all or nothing. You have to quit using all substances. And don't get me wrong, that's an absolutely spot on perspective and theoretical point of view. And Alcoholics Anonymous started in the mid 1930s, which pioneered saving millions of people's lives through the abstinence-based. But there's also there's other medications that can go hand in hand with the treatment of addiction that are relatively new and have been introduced into this world of addictions treatment. And the interesting thing, and Erin can piggyback on this, but only 60% of treatment facilities offer some sort of medication support in the early stages of addiction recovery, meaning people are going to need something for withdrawal from cravings, et cetera, to have them go through that process. But the other really alarming thing and a barrier is the training in our medical profession. And Erin alluded to the stigma, but also there's very few science-based treatment centers, and only 25% of physicians and nurse practitioners have received any training in addiction treatment. So they don't even know how to refer to a treatment program. So we're stuck upstream with the primary care physicians and the lack of education going in to make a proper assessment and diagnosis when when there is a patient in front of them that may have a substance abuse disorder.
Wow. I think that talks a little bit, and we could probably have another podcast about this, but just to let our audience know, you're already touching on the importance of integrated behavioral health care in general practitioners' offices. And I know Erin, being a nurse, can probably speak to that a lot, how it can help. And this might even be part of your answer, Erin, but I'll ask you the question just to piggyback off of what Dr. Valentine just said, is when people are ready to get the help. So now that we understand that there is some barriers in treatment, there's some limited aspects for science-based care, but hopefully things are shifting and they are changing. When people are ready to get the help and are ready for treatment, they decide, okay, I'm ready, which is a big piece. What is the best way to get the help that they deserve? In other words, what is the best path for them to take or for their loved ones to take when wanting to get help? Who should they call and where should they start?
That's a great question. So back in 2000, there was federal legislation that was passed, the DATA 2000. And it kind of changed addiction treatment in the United States. And what it did was it allowed office-based physicians to prescribe drugs to treat opioid addiction. So that would be some of the drugs. I'm sure you'll probably ask me about that later, but Suboxone, Subutex, all of those different types of medications.
And those are medication-assisted treatment, right?
Yes, MAT, as we call it, or yes, medical-assisted treatment or medication-assisted treatment. And so just to kind of go back to what Dr. Valentine was saying is there's a lot of facilities that treatment centers that just don't believe in MAT, do not believe in that. They feel there's a sense of we're replacing one drug with another drug, right? And that it's not treating the problem. But we found that actually patients that are treated with these medications, 40% and 60% of patients who suffer from the drug use disorders end up relapsing when treatment's discontinued. And the relapse rates are significantly lower for those that are treated with MAT.
Wow.
Those who are not.
So why wouldn't you not treat it? I mean,
we're going back to stigma, education. So if it was my family member, the first place that I would start is with my medical professional, I guess, where I would say, depending on, how much they've used, what they're using, if they have any biological or other like issues like chronic disease, if they're HIV, if they have other medical, that can affect your withdrawal. So we want to make sure that we go to a medical doctor, especially with alcohol too, as well, because alcohol and benzo withdrawal is one of those few. I always teach nurses that that's one that is deadly, and we need to really be aware of. It often gets missed. Delirium often gets missed in psych hospitals for psychosis.
For alcohol use disorder.
Yes. So we have a lot of work to do in training. I know I was a volunteer faculty at a university medical center BSM program, and during their 12-week rotation through psych, they had 1 day of chemical dependency training. One day. That's not enough. It affects every department, maternity, neonate.
Oh, absolutely.
Like I already said, emergency, med surg, chronic disease, all of those things, diabetes. Okay. Mm-hmm. All of those diseases have addiction component to it. We can do better.
Yeah, absolutely. I think there's that piece, right? Is if we can work towards behavioral health and substance use disorder being more integrated into all aspects of medicine, we may be able to screen quicker, notice who the patients are, or who people, they may be going in to see about their diabetes and monitoring their diabetic control. But if we're able to understand the role addiction can play even with people with diabetes, because there is risk with comorbid diseases, substance use disorder risk goes up, a way for people to manage their disease or their health state. If we can somehow have this integration of behavioral health and substance use disorder in these medical professions of practice, we might be able to screen and detect quicker and sooner, is what I'm hearing from you.
Right. Because when you go to your doctor and you're going to have the biological evaluation, but there's also psychological and social factors that contribute to a person's treatment plan. So having like an integrated team to address those needs is where we see the most success. The first step is going to be detoxification and acute intoxication or withdrawal. So starting with a medical professional is really imperative. So I would say, start with your doctor, see if you can get assistance. And then there's also amazing national helplines. SAMHSA has a national helpline, a 24 hours free confidential treatment. They give you referrals. They look at about your mental and substance use disorders prevention. They can refer you, and it's a 1-800-662-HELP or 4357. So that's where I would start with a family that had someone they were concerned about, a loved one. Start with your medical doctor, as you might need to be hospitalized, right, for an alcohol withdrawal. But if not, they can refer you to a lot of very verified programs that are going to be able to treat the whole person.
That is so helpful for the audience. Erin, our professional in substance use disorders and our very skilled nurse with plenty of practice, plugged SAMHSA. For the audience who may not know what SAMHSA is, it's the Substance Abuse and Mental Health Service Administration. It's an agency within the U.S. Department of Health and Human Services that leads public health efforts to advance behavioral health and substance use disorder issues in our nations and improve the lives of people with mental and substance use disorders. And so they definitely are a great place to start if you're looking for the care that you need. Dr. Valentine, was there anything else that you might want to encourage the audience to look for if they're looking for help? What are some other things that they should look out for? Should they look for places that have MAT medication, or what are some things that they could look for even on the website with SAMHSA?
Yeah, that's exactly it. I was thinking when you were talking about SAMHSA, it has a treatment locator on site, nationwide treatment locator. And I think that does a very good first brush screening job at identifying treatment facilities that are sort of vetted and at least have met certain minimum criteria around quality of care. There's a requirement to fill out an application and then submit it to SAMHSA to get on that referral list. So I'd start there as far as identifying different types of treatment programs that have emphasis maybe on what's called dual diagnosis, mental health and substance abuse combined issues. That's another up and coming kind of treatment program that's very important because we'll talk about this in a little bit, perhaps, about no wrong door, meaning no one's turned away if they have a mental health or substance abuse problem. But I think if it's primarily substance abuse, that SAMHSA resource is a great way to start. And as Erin said, the primary care physician, hopefully they can at least get a social worker or someone else to assist in making a good placement and referral.
I have so many questions for you guys, and I also have to be careful of our time. We're almost coming up on an hour, and I'd love to talk a little bit more about wrong door. But I think what we can do with the audience, if they like it, is we can do a substance use disorder part 2, understanding substance use disorders and addiction. Because like I said, we even all agreed on at the beginning of the podcast, is there's so much to talk about, and I think just having the conversation with professionals like yourself is helpful to our audience. With that said, being sensitive, and I know you guys are very busy, I wanted to just give an opportunity that if, as much as this has been a wonderful and informative interview, is there anything else you believe would be important for our listeners to know before we sign off today's podcast?
Well, maybe first thing that pops into mind, I'll steal the thunder here a little bit, Erin, from you. But okay. I want to leave that there's hope, that there are resources out there, and that to have a bit of compassion and empathy for an individual who's struggling with addiction. There are, again, many resources. We talked about some of the limitations, but addicts and alcoholics can turn their life around and create a healthy lifestyle. There's a lot of recovering individuals in this country who are grateful and have created a positive effect on society as a result of their recovery. So I want to leave it with that. Keep hope alive, as they say.
I completely agree. Erin?
Yeah, I totally agree with you. Although we have a lot of work to do, we have some very compassionate caregivers like yourself that have humanity. They find the humanity in the situation and they treat with empathy and kindness. And I think I would say making sure that families are involved in the treatment process, because the patient needs support, and they have a greater chance of long-term success with the whole family being involved in treatment. They know that recovery is possible, and they can help be educated and see the addict's trigger signs of using and important factors of, and oftentimes they are the ones that give the Narcan, and save lives within the home. Making sure that the family takes care of themselves. So just like the airplanes where we put the oxygen mask on ourselves, we need to do that as well for family. There's a lot of good treatment programs out there, Al-Anon, Alateen, Narcanon. There's a lot of different support groups that help the family take care of themselves, and then in turn, they can support their loved ones. So I guess, kind of a kumbaya, let's take care of the addict, but also take care of the family and themselves.
You two, thank you so much. I really hope that the audience takes away some of the great things that I took away from this podcast, just the education in general, not only just, some of the parts that we have opportunity to improve upon, but what you both just said. Let's leave it at that recovery is possible. Help is available. There are compassionate thought leaders and clinicians alike that know how to manage and treat substance use disorders. And people can recover and get better. And the same goes with families alike. We've been talking to Dr. Dan Valentine and Erin Carroll about substance use disorder and addiction in America. And I want to thank you guys both very much for taking the time out of your busy schedules to illuminate this very important topic. Thank you.
Thank you. Thanks for having us.
Thanks for joining us in this episode of Ready to Talk, Ready to Listen, all things mental health. Click to subscribe to our podcast on iTunes or Google Play. Until next time.